when we're talking, now your lower GI business, all that stuff is going to come to you in 201. Okay, that's when they're going to be talking about bowel and liver, pancreas, all that stuff. We're just talking upper GI for this course. All right, we're talking oral, esophageal, and stomach. Okay, so be aware that as people get older, there are physiologic changes that occur in their GI system. We've talked about lots of other changes, but their GI system is affected as well. Okay? They have decreased hydrochloric acid production in the stomach. So what happens is they get into trouble with the absorption of their nutrients, especially their iron and B12. They also have problems with gastritis, which we'll talk about, which is just an inflammation and irritation in the stomach. Their peristalsis slows down. That's why older people become more constipated as they get older. Okay? They get into trouble with impaction. Decreased fat absorption and digestion of fats. So what happens is they're losing fat in the stool so they can have diarrhea. They don't break down their protein quite as well as they did, and then of course you know that they have problems with drug metabolism. So when we're looking at our treatment for some of these things that we're going to talk about, not only do the physiologic changes affect their system, but it also can affect the way that we treat some of these conditions that we're going to talk about. So the first thing that we do as nurses is we're going to do our history and assessment. Okay, we've got to find out about the GI system. Has your patient had any changes in their appetite? Have they had any weight changes? And have they noticed any change in the character or frequency of their stools? We're asking about any kind of previous disorders, any kind of GI problems, GI surgeries. We're wanting to know about any medications that your patient's taking. Are you noticing that we're having to ask those questions about any diagnosis, any system that we talk about? Have you noticed? It's pretty much what we do. What's your problem? Have you had any changes? What medicines are you taking? Okay. What is your past history? When we're talking about medications, we're really, really interested in not only their prescribed medications, but also their over-the-counters, any supplements that they're taking. Is your patient taking any aspirin or any blood thinners? NSAIDs, always making them prone to bleeding. Is your patient currently taking laxatives or enemas? Your older folks become very, very bowel conscious, okay, and feel like that they need to have some type of bowel movement every day. And if they don't, then there's something wrong, okay? So a lot of your elderly people will be on daily laxatives, or they'll take enemas. So you need to know about those things. We want to ask about travel history. Have they been out of the country? Where did they go? Okay, not all countries are as they don't have the standards when we're talking about water and food and things like that we have here. So we do need to know. And just know that your patient's age, their family status, their socioeconomic status will play a part into their nutritional status. Okay? Maybe they need to pay rent or buy their meds before they can buy their food. We're asking about nutrition. Are they on a special diet at home? If they're a diabetic, or do they, do they have a certain number of calories that they do? What is their diet? If they're on Coumadin, how's their diet changed if they're on Coumadin? No green leafy stuff. Right. So we need to know those things. Have they had any change in their taste? As we age, we're not quite as sensitive with our taste buds, so our tastes change. Do they have any food allergies? Any anorexia? Do they just not have an appetite? What is dysphagia? Trouble swallowing, right. Any nausea, vomiting, pain, heartburn. And then, of course, we want to ask about family history. Always need to know that. We're looking for diabetes, cancer, any kind of GI problems in the family. We also want to ask about, and we are asking this because we ask everybody about their special culture and cultural considerations, religious considerations. Remember, there's folks out there that, they eat a lot of spicy foods. It's part of their culture. There are people out there who fast for periods of time as part of their religion. People that are vegetarians. Again, that's not religion, but that's just, their preference, okay, their culture or whatever. Some patients are lactose intolerant. You need to know about those things. And also, we're asking about their elimination history. Do you go to the bathroom every day? Do you have a bowel movement every day? Is that normal for you? There are people who do not have a bowel movement but once a week. That's normal for them. We're asking about their current health. We need a breakdown of the problem. What is the issue? When did it start? How long does it last? Okay. What are the specific signs and symptoms that the patient has? And then what do they do to alleviate those signs and symptoms? That's kind of your who, what, when, where questions there. And then we want to know, is there pain associated with the problem? Your book talks about the PQRST. What does P mean? What is the precipitating issue or the palliative, what makes it better? Okay? Precipitating or palliative. Q is the quantity or quality of the pain. Region or radiation is what the R is. Severity and timing. You want to ask all those questions. Ask your patient, where is it? Where is the pain? And when they say in my stomach or in my abdomen, that's kind of vague. Remember, we like to be a little more precise there. So always have your patient point to the area. Can you put one finger on the area? That'll let you know what quadrant it is, not just it's my abdomen. Okay? And then describe it. Is it sharp, dull, continuous, intermittent, sudden occurrence? What causes it? Again, we're asking about change in bowel habits and any changes in the skin. Why in the world am I concerned with skin changes if it's a nutritional problem? It can be dehydration, right? What else? Excessive vitamins can change your skin color. Trouble with the liver changes your skin's color. Okay. Itching, jaundice, increased bruising if they're having issues with their iron. Okay. Those type of things. Then we're doing our physical assessment. Think back to 103. How did you assess the GI system? How did you assess the mouth? What did you look at? Look, listen, and feel. The abdomen, remember the 4 quadrants? Right. We inspect first, then we listen before we palpate. Yes. No, no. Advanced nursing do percussion. Okay. That's advanced practice nurse, like your nurse practitioner. Okay. But remember, you're always going to inspect the abdomen first, then listen before you palpate. Why? What's the purpose of that? It can alter your bowel sounds, right? It can alter your bowel sounds. When you're doing a physical assessment, you want to make sure that you have your patient empty the bladder first. Okay. You don't want to be palpating a full bladder. They don't like that. When you're inspecting, what are you looking for? You're looking for distension, the shape of the abdomen. Is it distended? Is it even? Is there pooching on one side that there's not on the other? What else are you looking for? If there's waves in the abdomen, somebody who's very thin, you can actually see peristalsis. Okay? You should not be able to see peristalsis in me. If you can, something's wrong. Okay? Something is wrong. You're looking also for pulsation in the abdomen. If your patient has an abdominal aortic aneurysm, you may see pulsations in the abdomen. It's usually a bulging mass there. You never want to palpate that area. Don't touch it. Just contact your physician and let them know that's what you see. Peristalsis you see all over the abdomen, but this will be usually a bulging mass that you can see it pulsating. Don't touch it. When you're auscultating, tell me a little bit about bowel sounds. How do we chart those? They're present times how many quadrants? How do we know somebody has bowel sounds? What tells me they have bowel sounds? If you auscultate them, how do you know they have none? Nothing after 5 minutes. If you have silence after 5 minutes, then you can chart that the patient has no bowel sounds. All right. And remember, now we've talked about when would people not have bowel sounds? Right after surgery, right. Obstruction, with an obstruction, they will not have bowel sounds, right? Or they won't have bowel sounds below the obstruction. All right, good. Percussion, like Marcus asked, that's gonna be your advanced training, people. And then palpation. Light palpation at this level, just trying to make sure we don't have any tenderness or anything like that. All your deep palpation and that stuff's done by your physicians and your advanced practice people as well. Okay. Diagnostic assessment of the GI system. We can do labs, we can do x-rays, we can do scans, we do blood tests, stool tests, urine tests, all that fun stuff. CBC is going to be your basic test, your starting off test. We're looking for anemia and we're looking for infections. We're also looking at electrolytes, especially if your patient has had vomiting and diarrhea. Anything that affects fluids is going to affect your electrolytes. Liver enzymes may be checked. And when you have liver problems, your enzymes are going to be elevated. Urine levels of amylase and urobilinogen tells us about a little bit about liver function. Amylase tells us about the pancreas. You remember that? Amylase, lipase, those are pancreatic or enzymes, and then the bilirubin, ammonia, those type of things tell us about the liver. Urobilinogen. It is it's going to tell you if you have an obstruction in the hepatic or the biliary ducts, because those usually absorb and take care of it. Anytime you have liver problems, you have problems with bile, right? And bilirubin, so it settles out into the tissues, and sometimes it spills over into the urine. So urobilinogen. If we have issues with the GI tract, excuse me, we are going to be doing stool specimen collection and evaluation. Stool can be checked for all sorts of things. It can be checked for occult blood. We're looking for bleeding in the GI system. O and P is ova and parasites. Stool may be collected to evaluate for fecal fats. And you shouldn't have a lot of fat in the stool usually. It shouldn't be an everyday occurrence. Now, if you've had a really fatty meal, it may, but it shouldn't be an everyday occurrence. If you're continuously having a lot of fat content in the stools, there may be an issue with absorption. Okay. And then you can always test the stool for C. diff. Clostridium difficile is a condition that we've kind of brought along ourselves, where the overuse of antibiotics kills off the normal flora in the intestines. Okay, so you get this condition here, and what happens is it causes necrosis of the lining of the colon, and your patient has severe diarrhea. It is a contact precaution type of thing, so patients who have C. diff are put on those contact precautions. When I say contact precautions, what does that mean? Gloves, gowns, right. Yes. Yeah, once you diagnose it, you have to start contact precautions immediately. Absolutely. Good hand washing, good hand washing on these folks. Soap and water, because know that the alcohol cleaners are not effective against C. diff. So that's why your patients with C. diff, you've got to do that good soap and water hand washing. You'll have radiology exams done. Looking at, it may just be a plain old x-ray of the abdomen, but there are also scans, MRIs that we can do to light that up. CTs, I would look there in your book. There is a chart talking about some of these different procedures. We use a lot more CT now when we're looking at GI issues than we used to, but we still do upper GIs, okay, which is an x-ray where the patient actually drinks barium and they take a series of x-rays as the barium moves through the upper GI and also down through the small bowel. They call it a small bowel follow-through. There is prep for this, as in the patient has to be NPO. Right. We do hold their meds, anything that's going to affect their GI motility, because we're trying to see what is going on in that upper GI. So I would look at those things there, okay? Your patient may be ordered to have a barium enema, which is that's exactly what it is. It is an enema where they actually put barium in to light up the colon. Okay. So you have the prep for that just like you do any other kind of bowel thing, okay? Clear liquids, maybe laxatives the day before, the night before, and then you're going to have enemas until clear the morning of the test. You've got to clear out everything so we can see. It just lights up everything so that they can see. Now the thing about barium is you've got to make sure that it gets out of the system. All right, so after your patient has these exams, okay, we've got to make sure that they have a lot of fluids, increase their fluids, a lot of drinking, and usually we give these people a laxative to help push that on through. Your patients need to know that their stools are probably going to be white, chalky, milky looking for a day or two. That's normal. That's the barium moving on out of there. Okay. It sets up like concrete. Yeah, and then you've got whole other issues there. So it's usually that's just your routine. Patients who have that, they come back to the floor, get them to start drinking, increasing their fluids, and you give them some Milkamag with a light laxative with cascara to get it going. Marcus, I'm not going to take that in the middle of class, okay? You can see me at break. Thank you. Okay. So I would look at those tests. And become familiar, because these are still being done, right? Still being done. Know your post-op care. Know your post-procedure care. And then your scans, your sonograms, you can always have ultrasounds just to kind of look and see what's there. Other kind of diagnostic, this is kind of the standard now, okay, is we're doing endoscopies. We talked about some endoscopies when we were talking about peri-op, remember? How do we do a lot of these peri-op? What kind of anesthesia? Okay, let me start that again. How do we do a lot of these endoscopies as far as anesthesia? Not necessarily general. A lot of these folks have the moderate sedation or MAC, okay, because they're short exams. But not everybody is able to have endoscopy, so that's when we're really going to be looking at the barium enemas, the upper GIs, those kind of things. To look at upper GI issues, we do EGDs, which is an esophago-gastro-duodenoscopy, looking at mouth, esophagus, all the way down to the duodenum. It is a mouthful. That's why we say EGD. Colonoscopy, of course, is looking at the entire large intestine. Sigmoidoscopy is just looking at the sigmoid colon. Small capsule enteroscopy is looking at the upper lower. Good Lord have mercy, it's that kind of thing. Looking at the small intestine. And then ERCP, which is an endoscopic retrograde cholangiopancreatography, and I will not test you on that, is looking at the liver, the gallbladder, bile ducts, and the pancreas. Okay, that's kind of a high-tech endoscopy. Where do they go? They go to like an endoscopy unit or room in the OR or something like that. They can do a sigmoidoscopy at the bedside, but usually everybody goes to OR for sedation. I'm gonna need sedation. Thank you. Remember that. These are invasive procedures. Okay, so we need a consent. These folks are held NPO. We stop their anticoagulants. They are usually put on, like I said, moderate sedation. With an EGD, they usually spray the back of the throat with a xylocaine spray, which will diminish your gag reflex. Okay. Sometimes your patients will be given atropine to dry up some secretions. And for the exam, your patient is usually put in the left lateral position. Remember the position that you put your patients in when you gave an enema? That's kind of the position that you're going to do for your colonoscopies and your sigmoidoscopies. Your EGDs, they may be supine, but they usually turn them to the left also. Okay. Now, for the EGD, our goal here is to prevent puncturing anything and to prevent aspiration, maintaining the airway. We're putting a big old tube down their throat. With colonoscopy, again, we're trying not to puncture anything. But we're also, these folks have got to have the prep ahead of time. We've got to clean out the bowel before we can get in there and take a look. So they're held NPO, have the bowel prep. They're going to have the sedation. They may have atropine. Same thing goes for that. But post-op, your patient may have some cramping, bloating. They may have a little bit of bleeding. That's kind of normal after that. But your patient should not have pain. Okay? Pain and hemorrhage after a colonoscopy means that there may be something perforated in it. When your patient has an ERCP, that's using they go in through this way, and they go in orally and move over to the liver. You have to watch these folks, especially a couple of days afterwards, because they may not have any signs and symptoms of a problem for 2 days after the procedure. Okay, you've got to watch them for gallbladder problems, nausea, vomiting, inflammation, pain, those type of things. No, they go home. They go home. No. You have it done, and then they say come back if you have problems. They give you discharge instructions, and it's an outpatient procedure. But it's done in the OR, and they give you discharge instructions just like they do any outpatient person. These are the signs and symptoms you need to look for. Call us if this happens. Those kind of things. No, they don't keep them. They don't keep them overnight or anything like that. Mm-hmm. Yes. Because you've got a foreign body in there, and plus perforation. Yeah, it's a big deal. It's a little more involved than just having a colonoscopy and all that business. Yeah. Okay. All right. So, any questions about the assessment, history assessment? Look at those. Look at your lab work. Look at your procedures? What is your pre- and post-operative care for these folks? Okay? If you're working a med-surg unit, you're going to have a lot of folks going to have these tests done. All right, a lot of GI issues. So let's start looking at some specific ones. Let's start with the oral cavity, and the first one we need to talk about is stomatitis. This is when you have very painful ulcerations in the mouth, okay, inflammation of the oral mucosa, and it's just ulcers, basically. It can be caused from a variety of different items, okay. Chemo radiation is really harsh to the mucous membranes, so it affects the mouth as well. Some foods. Sometimes your patient has stomatitis because they're not very hygienic, okay, not good mouth care. Your book goes into talking about primary versus secondary. Basically, it's just primary is there's something in the mouth that's causing the ulceration. The primary site is there. Secondary means something else outside of the mouth has caused it. Okay, that usually means it's some kind of infection because the patient is immunocompromised. Okay. I'm more concerned that you know what you do with stomatitis than trying to differentiate secondary versus primary. But you think about somebody who has a red, raw, ulcers in their mouth. It affects their nutritional status because they don't want to eat. Their mouth is very painful. Okay? And if it's very severe, the swelling and the inflammation can actually block the airway. Sometimes your patients may have a condition in the mouth that's called Candida albicans, candidiasis, which is a fungal infection. Have you heard of that? What do we call that in babies? Thrush. We call it thrush. Right. But it is very painful. Okay. But usually with candidiasis, it's a white plaque lesion, like type lesion. Okay. You can usually wipe that away, and then underneath it is very red and very raw. So what in the world are we going to do about it? The first thing that we've got to do is we've got to implement very good, careful oral hygiene. Got to get the mouth clean. Mouth care needs to happen every 2 hours using a very soft bristle brush, toothbrush, or those foam swabs. You can use those as well. The mouth needs to be rinsed every 2 or 3 hours with a saline solution or maybe warm bicarb solution. And please do not have your patient use mouthwash. That's pouring alcohol on a blister. That's not fun. Patients don't need to have their dentures in. Sometimes ill-fitting dentures can cause this. So good oral hygiene. We're going to start them on some medications. We usually start them on some antibiotics. Depends on what the problem is. If it's a fungal, if it's thrush, we're going to start them on antifungal. If it's a bacterial infection, we're going to start them on antibiotics. When we're talking antibiotics, usually we're talking about tetracycline, which is a topical medication that we can put on there 4 times a day. Antivirals like Zovirax. Some of your herpes simplex, those are viruses, and those can lead to stomatitis, so Zovirax is used for that. Antifungals, maybe nystatin, mycostatin, and these are things that the patient actually swishes and swallows they swish it around in their mouth and then swallow it. Okay? It's a topical. Which one? Whichever one. Nystatin is Nystatin. And mycostatin is MYCO. Your immune modulators, these are like steroids, may need to be given. And then there are some symptomatic topicals that you can use. Things like topical xylocaine that you can that they can actually swish in their mouth and it deadens the inner lining of the mouth. Or gel is one of those things that you can get over the counter. There is a viscous lidocaine that your patient can gargle with to deaden the mouth. And then what kind of dietary changes do you think we need to implement? No spicy foods. What else? No acids, no salty, right. Cool liquids, no warm stuff, okay? Cool liquids. They could have dairy products. It just needs to, they need to stay away from the acidic stuff, like the acids, orange juice. No orange juice. Okay. No real hard, crunchy foods. Sometimes there are foods that your patient is eating that can trigger an allergic reaction that can lead to stomatitis. Your book talks about this. Things like potatoes. Oh, Lord, help me. Potatoes, coffee, cheese, and nuts. Oh my God. The fun things in life. Okay? Coffee, potatoes, cheese, and nuts. So might as well add chocolate to it, hadn't it? Keep in mind there are some vitamin deficiencies that can lead to ulcers in the mouth. Okay? Things like B12, B-complex, folate, zinc. Okay? So again, nutritional status, looking at how they are. Okay? So stomatitis, it's an ulcerations. We're going to good mouth care, start them on their medications, and we're going to alter their drugs, alter their dietary, alter their drugs. Yes. No, it's only in the mouth. Only in the mouth. Right. Okay? Questions about that one? Let's move on to some pre-malignant lesions that you may see. These are leukoplakia, which are white, and then erythroplakias, which are red. Okay. These usually come from irritation in the mouth, like bad dentures, broken teeth, tobacco, okay, some of your snuff and chewing tobacco. But the leukoplakias are white. They're usually benign and comes from long-term irritation. Your erythroplakias are red, and these we need to biopsy. Those are the ones that we are more concerned with. Some of your white, your leukoplakias are really can be just an opportunistic infection that happens. Do you know what I mean when I say that? It means that they're immunocompromised, so normal bacteria and organisms that would come in contact every day take the opportunity to flourish and become established in your patient. So opportunistic infection. You'll hear that quite a bit throughout the rest of the program, okay? Especially in those things like HIV, lupus, things where your patient has immunity issues. Okay? So the lesions, we're going to biopsy them if we need to and watch them, okay? They can become cancerous. When we have oral cancers, usually 90% of them are squamous cells, slow growing. And notice that the earliest sign is erythroplasia. Okay, swelling, redness of the mucosa. Your basal cell cancers usually affect the lips and usually come from sun exposure. Usually asymptomatic, it's just a scab. Anything that is red and raised and eroded needs to be checked. Any area that has not been healed within 2 weeks, or if it looks like it's thickening or getting bigger, that needs to be checked out. And then Kaposi sarcoma, we see those are really dark red, purple splotches that we see. When we're talking about the mouth, it's usually on the hard palate, but Kaposi sarcoma is an you see this in folks who have AIDS. It is a cancer, and they're really dark purple reddish splotches, and they can be all over the body. Most of your oral cancers come from some type of tobacco use. So when we're assessing, we're looking for lesions in the oral cavity. And we're looking for patients that are having, patients will present, they may present with, I've got this like sore in my mouth, or I've got this, I'm not able to chew on this side of the mouth because, that's how they present to you. Difficulty in chewing, swallowing. But your malignant lesions are usually, like I said, ulcerative, they're sore, and they're thickened in appearance. You good? Okay. I flashed it to the next one. Right? Anything suspicious has to be biopsied. Your patient has these issues. They may have alterations in speech. Now that's a pretty big growth if they've got an alteration in their speech. Enlarged cervical lymph nodes. It's an ulcerative type thing, opened area. Ulcerous sore, and it has a thickened appearance. The patient with oral cancer usually has a poor appetite. So tell me, I've got a couple here, fear of cancer and disturbed body image. Tell me, if someone has an oral cancer, what type of nursing diagnoses can you think of that your patient may have? Nutritional imbalance, higher or lower than what the body needs? Lower than what the body needs. What else? Impaired skin integrity. What else? Pain. Anxiety, you betcha. What else? Altered body image, because we may have to do some surgery, which we'll talk about in a minute. Knowledge deficit about treatments and long-term care. Exactly. What's the biggie? What's the biggie? Airway. Potential for impaired airway. Impaired gas exchange, I guess is the nursing way to say it. But airway. Okay? Good. Impaired communication. Those type of things. So when we have an oral cancer diagnosed, non-surgical management is going to start immediately. We're going to look at that airway. Do we have a patent airway? Assess for dyspnea, respiratory effort. Okay. Is this blocking their airway? Patients with oral cancers, their secretions are usually thickened. Okay. So they have issues with moving those secretions around. Okay. So we want to do deep breathing, coughing exercises. Think back to your turn, cough, deep breathing business. Okay. Semi-Fowlers to high Fowlers positioning for good lung expansion. These patients may need to have chest physiotherapy. Do you know what that is? Where they're beating on the back. Do you remember that? To try to loosen some of those secretions. Patients are usually put on steroids, antibiotics, and we always put these folks on aspiration precautions. Thickened secretions means protect that airway, have suction at hand. Suction should be available, and because they're at such a risk for aspiration. We want to do good oral hygiene. Again, the same kind of stuff, every 2 hours, soft brush, those kind of things. We've got to be careful though. Patients who have cancer, their blood levels can get out of whack, so we have to monitor their platelet levels for sure, because the mouth is very vascular. So if their platelet level falls below 40,000, we're going to be extra gentle in our care. Okay. And then another non-surgical management is chemotherapy and or radiation for these folks. I don't know that I can give you statistics on that. That's really doctor's preference. I believe it would have to do with where it is and how easy they can get to it. I think a combo is what they use a lot of. But as far as statistics, now when we start talking about surgical management, okay, surgical management for oral cancer really depends on how big the lesion is and where it is. Okay, your larger lesions, smaller lesions, we just put them, they just go in, they may freeze it, cryotherapy, okay, just a little local procedure. The patient usually has liquid to soft diet afterwards, but really there's no limit to their activity. There's no really no limit at all. No really need for analgesia post-op. It's just a small lesion. It's when the lesions are a little larger that we may have to go in and do some resection there. This is when we're talking about radical excisions. Your patient who has a radical excision may also have a laryngectomy. These are very radical neck, mouth, facial surgeries. What's my number one priority post-op? Airway. I'm messing up all this business right here, okay? So your patients may come out of there with a tracheostomy. They're going to have oxygen. And we're going to do our routine post-op care. Vital signs, airway, turn, coughing, and deep breathing. Okay. Frequent vital signs. These folks are held in PO for anywhere from 7 to 10 days. We're not feeding these people. We will start them on enteral or parenteral feedings if need be, but it depends on how radical the excision has been. Was there any danger to the esophagus? Patients following the radical excision may need your thickened liquids for a while. They just can't handle that those real thin liquids like water. You may have to thicken that. But we start them slow. Pre-operative, we're really just going to review all that with the patient just like we did. They need to know if there's a potential that they're going to come out on the ventilator with a hole in their neck. Please let me know that ahead of time. So all those things that we talked about last week, we're gonna give them all that information ahead of time. Post-operative, got to make sure good, gentle oral hygiene, maintaining the airway, good trach care. These people get humidified oxygen through these trachs and all. Yes. They're usually NPO for 7 to 10 days. Now that's nothing by mouth. That doesn't mean that we may not put in a feeding tube or start them on TP1. But nothing by mouth for 7 to 10 days. Infection prevention. Very vital up here. Okay. Pain control. Nutrition. The patient needs to know that they're probably going to have some changes to their taste. And they may have some problems in swallowing post-operative. Got to check for that stuff before we feed them. How do you think these people communicate? That's if they've had a laryngectomy, right. But post-op with a tray, you're telling me all different kinds of things, and that's great because there are many different options. However, when do we decide this? We need to talk about this pre-operative. Remember, if the patient's going to not be able to communicate with you after surgery, they need to know that, and they need to know this is how you're going to talk to us. You're going to write it, however, you're going to have pictures that you can point at. Decide that ahead of time. These folks will have problems communicating. These folks are going to definitely have problems with disturbed body image, especially if you have removed the bottom jaw, half of the bottom jaw. Okay? They may have their tongue removed. Okay? It's a very radical excision there. All right. Questions about any of that? Looking at lymph nodes and everything. The big surgery, yeah, just radical. Okay, let's talk about esophageal problems. Do we need a break? Oh, okay. Now we're going to start talking about esophageal problems. These are in chapter 57. One of the main ones that we want to talk about is gastroesophageal reflux disease, or GERD. This is really a common, it's pretty common out there these days. It's really a backward flow of GI contents into the esophagus. Okay. Yes. The stomach and duodenal contents irritate the mucosa, and it causes inflammatory changes to the esophageal mucosa. It does. It does. It erodes the esophagus. What happens is it's due to really a problem with the esophageal sphincter. Large meals, spicy food, medications. It may just be a delayed emptying of the stomach. Or it may just be due to obesity, which is causes an increased intra-abdominal pressure and intragastric pressure. So what happens is the esophagus actually gets fibrotic, scarred, and it can lay down as it keeps trying to rejuvenate itself and lay down good new tissue there. But what happens is the scarring can actually predispose your patient to esophageal cancer. The epithelium that it lays down is in a brick-like pattern, and if you ever hear somebody that has a Barrett's esophagus, that means it has this brick-like appearance to where it's from the constant scarring of the esophagus, and that patient is at higher risk for developing esophageal cancer. Usually people with GERD have it at night, and it's usually when the patient is laying supine. Okay. Barretts. It's like somebody's name, Barrett. So what do you have? Your patient complains of dyspepsia, which is heartburn. They have regurgitation. And with their heartburn, it's a very severe burning sensation. It's usually substernal, and it can radiate to the neck and jaw. That's why some people get it confused with chest pain, cardiac pain. But with GERD, it usually happens after a meal, and it may last 20 minutes to 2 hours. It just depends on what they ate, okay, and how fast the stomach empties. All right. So chest pain is different than that. They have the same symptoms, but it doesn't happen just because they had a meal. Okay. Chest pain is cardiac in nature. This is GI in nature. But you have to figure out which one it is. You have to assume it's cardiac until you rule it otherwise. Okay? Your patient will have coughing, hoarseness, wheezing at night. Okay, that's just from the reflux back to the larynx, and it can damage the larynx. Dysphagia, which you've already told me is difficulty in swallowing, and odynophagia is painful swallowing. Painful swallowing usually happens when you've had chronic GERD. You've had it for a long period of time. The patient has a chronic cough. And again, they may have that atypical type chest pains. Anybody in here have GERD? Yeah. More of you will have it by the end of nursing school. They do have belching, bloating, gas after eating. You can have. But if anybody's ever had that regurgitation, which is where it comes all the way to the back of the throat, who's had that? Boy, that'll wake you up in the middle of the night, won't it? Yeah. So this is something that can be potentially it is damaging to your upper GI tract, and we do have to try to take care of it. Non-surgical management, we're going to start out with nutrition therapy. Our goal is we want to relieve the symptoms of GERD. We want to prevent complications, and we want to treat the esophagus. Patients with GERDs always has a risk for aspiration. Always at risk for aspiration. So we're going to start out with some nutrition therapy. We want to try to limit or eliminate those foods that cause it. Nothing fried, nothing fatty, nothing spicy. Okay? The fun stuff of life. Nothing with too much caffeine in it. Coffee, tea, colas, carbonated stuff. Yeah. Yeah. Okay. No alcohol. Okay. So, they take everything away. All right. Patients should eat 4 to 6 small meals a day instead of 3 big ones. Don't overfill the stomach. No snacks in the evening. No eating within 3 hours before they go to bed. They need to sit up after they eat. Eat slowly. Chew thoroughly. Those kind of things. Let's see, what did the doctor tell me one time? There was no fried, fatty, fluffy, yeah, like your whipped stuff. And there was another F, and I can't remember what it was. Fun, probably. No fun food. Huh? Don't eat. Yeah, there you go. Yeah. Lifestyle changes. Got to talk about those. You got to lose weight, and you got to stop smoking. I stopped smoking. The other one's a little harder. Okay. Elevate the head of the bed 6 inches at night. That helps to kind of keep your patient in a semi-Fowler's. Your patient should be encouraged to sleep in the left lateral position. Avoid tight clothing. Avoid working in a stooped or bent over position. Again, that has to do with the intra-abdominal pressures and all that business. Kind of being pregnant. Yeah. Yeah. Okay. Drug therapy. I've got them listed here, but there are some drugs that we need to avoid. Some drugs predispose us to reflux. Things like anticholinergics. Oral contraceptives are bad about that. Your beta blockers, your nitrates, and your calcium channel blockers. Now we're talking about cardiac meds, right? Cardiac and blood pressure meds. Calcium channel blockers and nitrates. Anticholinergics. Anticholinergics, oral contraceptives, beta blockers, nitrates, and calcium channel blockers. Avoid those. CHOLIN urgix. Okay. So drug therapy for GERD, and these are really becoming things that physicians are really more prone to give nowadays. One of the for me, when I went, the doctor and I went for something totally different, but he asked me about it. And of course, yeah, I have it. But what he was telling me is that they can give up to they have some patients that take up to 21 tablets a day simply for their GERD, because it has come to the forefront about how you got to get this taken care of so that you don't have esophageal cancer. Okay, so they start out with a certain protocol and then they gradually advance it. They were even, you can even get to a point to where your patient is taking anti-anxiety medication, sleeping pills, those type of things. I'm not to that point yet. I'm still on some of those. But your drug therapy is based around these medications right now. Antacids, things like your Mylanta, Maalox, these actually neutralize the acid that's in the stomach. Now, your patient needs to take these medications a certain way. They take them on an empty stomach. So an hour ahead of meals is when they need to take it, or 2 to 3 hours after meals. Antacids are on an empty stomach. Correct. Yes, those are antacids. Gaviscon is one that they're really using now, and that what it does, you take it, it's going to screw you up because you take it with food. Gaviscon floats on top and causes a barrier there against the acid. So what they're finding is that those of us who have taken Tums and Rolaids for years, and if you wake up in the middle of the night, that's what you're sucking down is Tums and Rolaids. Now they're putting us on Gaviscon because it tends to work better. Rolaids and Tums, after a period of time, can cause reflux. Okay, so Gaviscon is what they're using more of now and having people take at night. And even throughout the day, I found you can take up to 14 of those a day. That's what I'm told. I'm not taking that many, but you can. That's like your maximum there. Okay? So antacids, empty stomach. Gaviscon we're going to take with food. All right? Your histamine receptor antagonist. These are your medications like Tagamet and Zantac. Okay? These actually reduce the acid production in the stomach. That's how they work. Y'all, these are on page 1207 in your book. Your proton pump inhibitors. This is your Prilosec, Protonix, Nexium. These have really become more of your main treatment at this point, or your proton pump inhibitors. What these things do is they last longer and they inhibit the secretion of gastric acid. These are the things, remember we talked about some of your patients may be at risk for ulcer formation from having surgery and being hospitalized. That's why we give Protonix now prophylactically to try to prevent some of that from happening. And that's how Protonix works. It decreases the secretion of gastric acid. When you're giving proton pump inhibitors, you have to be careful about long-term use because it affects calcium absorption. So if you're not absorbing calcium, what does that put your patients at risk for? Osteoporosis, fractures, things like that. Okay? So hopefully we're not using the proton pump inhibitors long term. Then prokinetic drugs. These are the drugs like Reglan that causes the stomach to empty faster. And again, we don't have people on long-term Reglan because it has some adverse effects like tremors, increased anxiety, dizziness, trouble walking, those kind of things. So we don't use those long term. So we got to get them eating right. We got to change some of their a few lifestyle changes, and then we're usually going to do some drug therapy and address the medications that they're on. Now, there is surgical management for reflux disease. These are a couple of them here. Endoscopic procedures, I'm not concerned that you spout this back to me. You're not going to be doing the surgeries, okay? But endoscopic is where they can actually go in and cut the vagus nerve, which decreases the vagus activity to the stomach, decreases discomfort, etc., etc. Suturing system, where they close off the esophageal sphincter. And then when we're talking about laparoscopic fundoplication, we're actually going in there and rerouting that around that esophageal sphincter. I'm more concerned that you know what to do post-op. These patients stay on clear liquid diets at least 24 hours after surgery. Then we're going to progress them to a soft diet if they're able to tolerate that. Okay? Remember, we've done surgery on the GI system. We've got to start slow. We don't, because they have a risk for perforation, leaking if they've cut and tied things back together. They have a risk for paralytic ileus. So we've got to really start slow with these folks. Okay? We don't give these people any kind of NSAIDs or aspirin for 10 days post-op. Meds should be liquefied. And we do not want to put down any kind of NG tube or other tube into the esophagus for at least a month post-op. The post-op care is talked about on page 1208 in EGI, chart 57-4. So just think about it. They've had esophageal surgery. We don't want to go shoving Doritos down through there. Okay? We don't want to be putting tubes down there if we do that. We want everything to stay, connected and tied together and all that business. So we have to be careful there. All right. Hiatal hernia is another esophageal problem. You may also hear this called a diaphragmatic hernia. This is where part of the upper part of the stomach actually protrudes through the hole in the diaphragm. It may be a sliding or a rolling. Okay. Sliding just means the junction and part of the fundus slides up through there. And the hernia moves freely. Okay, the whole thing moves up and down. When we're talking a rolling, the esophagus stays where it's supposed to, but the stomach rolls up. Okay, so it rolls up over the end of the esophagus. These people are more at risk for having some type of obstruction or strangulation, because it can roll up through there and strangulate. That's what we have to be concerned with, is any kind of hernia. That something comes up through the opening and stays. It may be an incisional hernia, any of that stuff. We have to be careful about strangulation. The diagnostic test there is a barium swallow, where we have the patient drink the barium, light up the esophagus and down to the stomach. You can also see the diaphragm. You put your patient in different positions to see if anything coming up through the diaphragm. Simple as that. Your patient may be asymptomatic with a hiatal hernia, but usually they have some GERD issues. Okay, they have heartburn, regurgitation, pain, those type of things. And with a hiatal hernia, the pain is usually worse after they eat or when they lay down. With GERD, it can be any time. in the case of a rolling hernia, your patient feels really, really full after eating. They may even have some shortness of breath, difficulty in taking a deep breath. Like you said, pregnancy, you know. And the symptoms just get worse when they lay down. So when we're talking about what we do for it, we can treat this non-surgically, just like we did GERD, okay? With our changing our diet, elevating the head of the bed, small meals, medications. But we may need to do some surgical procedures as well, okay? And our nurse's role, and the surgery for this is kind of like the one for GERD, the fundoplication. But preoperatively, we need to make sure that our patient is educated, just like we have for other things. And we're really going to be more concerned with doing surgery on these folks if aspiration becomes a huge risk. They're always at risk for aspiration. But if it's really, they've gotten to where they cannot, they're having too many signs and symptoms, a lot of reflux, then surgery may be the way we need to go. If they're having bleeding, then surgery is where we need to head. Okay? So pre-op education, these folks need to know that they're going to come out of surgery with an NG tube in place. So we're doing surgery on the lower part of the esophagus and the connection with the stomach. Okay? So these folks are going to have an NG tube in, not for feeding, but for decompression, to keep the stomach empty, to let the incision heal. The NG tube will be hooked up to low suction. Remember how we talked about the other day, how you're going to measure intake and output with that. Okay. And people who have had gastric or esophageal surgery and have had an NG tube placed during the surgery, leave it alone. Don't mess with it. You're monitoring it. Okay? You can't irrigate it. You can't reposition it. You can't take it out. You can't do anything to it without a physician order. Post-operative, we need to be aware of complications. They'll have the NG tube for a while, and then we'll take that out, and then we'll slowly advance their diet. But again, we got to watch for swallowing problems, aspiration issues, the same kind of things. Bloating, okay, got to look for ileus. They have the other risks that we've talked about, pneumonia and atelectasis and all that business, DVT and all that business. Okay, but post-op hiatal hernia, these folks can't have anything carbonated. We don't want to blow up the stomach. No chewing gum, no drinking with a straw. All that lets air into the stomach. We want to make sure that we watch the first oral intake that your patient has. Okay? And we're looking for those complications. The patient needs to not do any kind of straining, pushing, pulling, lifting. Hopefully they're not doing any kind of prolonged coughing. We talked about how important it is to turn, cough, and deep breathe our patients. In the case of a hernia repair, or in the case of eye surgery, or in the case of brain surgery, we're not having our patients cough. Hernia, eye, and brain surgery, we don't cough. We're still going to turn, and we're going to deep breathe and do all that business, but we don't need that extra pressure there. Okay? Respiratory care post-op hernia repair is the same as for everybody else. These folks may have a chest tube, just depends on how much they're into the pleural space where the hernia is. Okay, but not everybody has a chest tube when they come out from hernia surgery. Nutrition-wise, again, we're going to start off their feeding slow. We may even start to feed them by their NG tube. But that'll be a few days post-op, not immediately post-op. Their oral feedings, once they start, are going to be small. Okay, small, frequent feedings. And then they need to know what to avoid, those gassy, carbonated fluids and foods. Are y'all seeing some patterns here? Okay. Questions about GERD or hernias? Okay. Esophageal tumors. Patients may have esophageal cancer. This is usually a very slow-growing type of cancer, and it is usually fatal because the patient is asymptomatic until it's very progressed. Okay. Esophageal cancer spreads to the lymph nodes, then to the liver, and then to the lung. And of course, risk factors: tobacco, alcohol, long-term reflux disease. More prevalent in African American men. Yeah. I'm sorry? You can. You sure can. My uncle had this, and the way they found it is he had a spot on his liver. He was having chronic pain here. And so when they did the CAT scan, they found the spot on his liver. And then when they did the whole big scan, it originated from esophageal. It spreads to the liver and the lung via the lymph nodes. He had a PET scan. At first he had a CT, then PET scan. He passed away. It had already metastasized. He fought it a long time, but it had already metastasized. So when we're doing assessment, the first sign that we see, we want to try to catch it early, but like I said, they don't have symptoms. They may not have symptoms. But when they do, it's usually a persistent, progressive dysphagia. They start off having problems with solid foods, especially meats. And then that gradually progresses to where they have trouble swallowing soft foods. They lose weight. They have painful swallowing. And usually their pain is substernal and high, up high. Regurgitation. Your patient may have bad breath or halitosis. chronic hiccups, and if it is up high, Ms. Valerie, they have porcelain and laryngeal issues. Usually a complete obstruction of the esophagus is a late sign of an esophageal tumor. And again, we're going to diagnose this with the barium swallow. Light up the esophagus and see what's going on there. Non-surgical management. Notice that nutritional support again. Okay. A lot of times these folks are dehydrated, malnourished. Got to get them up to a good, healthy level if you can. Correct that. These folks may need liquid supplements like your Ensure, Boost, those kind of liquid supplements. Thickened liquids because, again, they're at risk for aspiration. And sometimes your patients just may need to have a G-tube put in. In this case, we're not wanting to go NG because we're going down through where we may have to be doing some surgery, so we put in a gastric tube. Patients are going to need swallowing therapy. They can bend their head forward, helps to swallow, and that exaggerate. And they're taught that. So anybody who has swallowing issues and needs swallowing therapy needs to have a speech consult. Okay, so that they're taught that exaggerated swallowing. Okay, that those techniques for prevention of aspiration. Sometimes giving your patient a lollipop helps to strengthen the tongue and aids in their swallowing. Chin tuck for swallowing helps it to go down. And then actually placing food, teaching your patient to place the food in the back of the mouth instead of up front and then trying to swallow it all the way back. Lots of different techniques. Chemotherapy, radiation, or radiation may be tried. Photodynamic therapy, where they actually are zeroing in light on the area. And then sometimes your patient actually has to have a dilation of the esophagus to just open it up so they can get something done. Okay? That's usually done PRN. It's done as an outpatient. And it may need to be done several times. Okay. Now, your surgical care for this is pretty radical there. Okay. Esophagectomy, where they actually remove part or all of the esophagus. Esophagogastrostomy, where they remove the esophagus and the upper part of the stomach. Depends on where the tumors are. Okay. They may need to have a radical neck dissection, which we talked about earlier with oral cancers. But radical neck is really going to be happening if it's in the upper part of the esophagus. Okay. Which makes sense. Y'all know that. Colon interposition is when the tumors have spread to the stomach, and they actually use part of the colon to substitute for the esophagus. We're not doing that surgery now. That's UAB business. I don't know that they do that in Huntsville. So pre-op care. Good nutritional support. Pre-operative. These people need to be in the best health that you can get them. Okay. 5 days to 2 to 3 weeks before surgery, we're going to start working on their nutrition. They've got to quit smoking. We're monitoring their weight, their I's and O's. They need a dental evaluation, looking at the mouth, okay, looking at the upper esophagus. We're going to teach these folks again about their post-op care, what to expect, what kind of equipment that we're going to be using, how we're going to monitor them post-op. Okay. These folks are going to come back to you post-op. They are going to be intubated, and they're going to be on the ventilator for a day. For at least 16 to 24 hours, they're going to be on the ventilator. Once they're extubated, we're going to start the turn-in, cough-in, deep breathing. This is spirometry, good monitoring of their vital signs, their O2 sat, assessing their breath sounds, all that good care that we've been talking about. Okay. These folks need to be kept in semi-Fowler's position. They're on antibiotics. They're getting oxygen. These folks are probably coming out with chest tubes. Semi-Fowlers, yes. More than likely, these folks are going to have chest tubes. Probably one on each side. Okay. They're going to have an NG tube that you will not, cannot, must not touch. So our post-op care is going to look at airway, always, nutrition, and wound care. We've got to watch these folks for infection. We've got to watch them for fluid overload. Remember, we're watching their I's and O's. Okay? These folks will be NPO for about 3 to 5 days. And then they're probably going to be started on TPN. What is TPN? Total parental nutrition, correct. This is covered in great detail in chapter 63, which I'm going to lecture on. If you're comfortable with TPN, okay. If you're not, I would for sure review that. Okay, that's a big deal. TPN's a big deal. We're gonna gradually progress their diet. Okay, let's see what they can tolerate and how they can do. So nutrition is watching closely, and then wound care. Once these people get home, it's just routine home care. Infection prevention, hopefully by the time they go home, we've got them on something oral that they're taking for nutrition. But just keep in mind that these folks can lose up to 10% of their body weight. Bless you. So we want to keep these folks on high calories, high protein diets, soft, something that's easily swallowed, and small, frequent meals. These folks actually need 6 to 8 meals a day. Remember, they've had the esophagus removed or cut in half or shortened, or maybe it's part of the colon that's there now. So you can't go eating a whole lot of big meals. 6 to 8 small meals. We want them to drink their fluids in between meals so that they're not filling their stomach with fluids and not food. Yes, ma'am. Or no, it takes part of it in part of the upper part of the stomach. This is in the low. That would be in the lower part of the esophagus. So it's the removal of the lower part of the esophagus, the upper part of the stomach, and then it's sewed back together. I'm sorry. Let me clarify that. Mm-hmm. Yeah. These people are at an even that are post-op these procedures. Remember, these folks have nothing to hold food in the stomach anymore. That sphincter has been affected. So the only thing that's holding it down there is gravity. So these people have to sit up to eat. Okay. Always in the upright position for food, feedings, anything like that. Airway, nutrition, and wound care. All right. Esophageal diverticula are little little sacs that herniate in the esophageal mucosa. Are you noticing a lot of the same signs and symptoms? Okay. Dysphagia, regurgitation, a lot of coughing, because food and halitosis, food liquids get caught in those little pouches. That's where some of that coughing and halitosis comes from, because it just gets kind of stagnant in there. Your patient always has a risk for perforation. Anytime a patient has any kind of diverticula, they have a risk for perforation. We diagnose this by doing an EGD, actually taking a look in the esophagus, seeing what we see. Again, we can treat these things surgically or non-surgically. Again, they need nutritional support. They need nutritional support. Again, the size and frequency of their meals, smaller meals, more frequent. We want to avoid reflux in these folks. So what are some of the things that I've said avoids reflux? Sit them up after eating. What else? Watch their foods, what they're eating, right? The amount that they're eating. No smoking. Correct. No alcohol. Okay. Now, surgical management is just going in there and removing the diverticula. Going in there, snip, and putting a few sutures in. Depends on how big the diverticula are. But your patient is usually in PO for several days. Remember, it's got to heal. You can't start putting a bunch of food down through there over a surgical incision. Okay, so gotta hold them in PO. They've got an IV. We may be doing tube feedings for a few days, and then we gradually progress them to PO foods and fluids. Okay. Again, they're going to come out with an NG tube, and you cannot do anything with it. Sure. No. You're not manipulating that tube at all unless the physician has given you an order to. You don't just go in there and start putting things in and out of it. Okay? If it's being used, if you've got an NG tube that's just for decompression, okay, but a surgical one that's put in because of a surgical procedure, you got to have an order for Does that book contraindicate that? For the purpose of the test, you don't touch it. You don't touch it. And again, your physician may say, go in there and irrigate it and see. But you learned when you were learning about tubes and those NG tubes, how do you check placement? Can you pull out stuff? What if you're pulling something and you're up against that suture line? You can, you see what I'm talking about, right? So just be very careful. Now, your physician may say go in there and irrigate it. That's fine, but write the order, and then you can go do it. You just don't want to just jump in there, because you can do a lot of things to NG tubes to keep them patent without an order, but when they're in there for this reason, you have to be very careful that you're not messing up a surgical procedure. Okay, we have the stomach left. Do we need a break? Yep, okay.